Welcome back to Fertility Fact or Fiction. I am your host, Dr. Rahi Victory, with a very weird voice because I have caught some kind of bug. And so we have the Milan background because I am not at home at the moment. But I hope everyone is doing well. I am fresh back from our trip to the European Society of Hormones and Reproductive Endocrinology with many of my team members, where we had a great learning experience and found out that we were either already doing everything that had been mentioned or were ahead of what had been mentioned at the conference. So it was a very reassuring meeting for us. And it's good to be back home and back in action again. So thank you for joining us. While we were getting ready to go away, this super interesting study came out, which I'm very excited to share the results of with everyone tonight. And hopefully a lot of you joining us tonight will be learning about this. So if you're new to our show, just so you know how we kind of run things, we often present a topic and then we take your questions live and try to answer them as best we can. And this topic is about how many times you should try. And it's targeted for low prognosis patients, but they also have information on normal responders. So it should be quite useful for everyone out there who is struggling and trying and wants to know how many cycles of IVF or frozen embryo transfers or timeline makes sense for them in their journey. So this is probably one of the better done studies in that regard. It's not perfect, no study is, but it should provide a lot of valuable information. So hopefully you'll all pick up on that. And if you have questions, don't hesitate to ask us and we'll go through them all. So just as everyone jumps on, I will start taking questions after we're done the initial segment, and we can go over your live questions and address those as best as possible. There certainly were some interesting things that came out of the ESHRE conference. Probably the biggest one was whether or not we should be using progesterone instead of antagonists for certain segments of the population in terms of their IVF cycle. So a lot of places have been doing that, and that's actually part of this study as well, where they're using progesterone right from the start to prevent ovulation. And it's a much cheaper alternative to using antagonists. And the question is it as good? And a lot of people at the conference were saying it was as good, and in some cases it might be better than even using an antagonist or an agonist. So we're going to look into that. I need to dig deep into the research. I wasn't completely convinced by what was presented, but definitely some interesting information out there. And you'll see in this study that in certain places it is very widely available and used. So a lot of information on that coming up. Okay, so with no further ado, this is a very interesting study looking at live birth rates for low prognosis patients over 5 years or up to 9 frozen thawed embryo transfers. And essentially what they wanted to do was look at all of the women that had undergone frozen embryo transfers and see how many times it was reasonable to do this before your rates either plateaued or went down or were no longer valuable in continuing. So very large group of patients. This is from a Chinese institution. They had 17,698 women who went through IVF cycles. And all of them were initially thought to be poor responders for one reason or another, but then subsequently got classified into various categories based on their Poseidon criteria. Poseidon is a system of calibrating who is, in which category for prognosis. And it's an individualized egg yield kind of criteria system. So they took the data and they considered the ones that made more than 9 eggs or had an antral follicle count of more than 5 as being the group that was their control group, and they compared everybody else to that control group. So everyone underwent an IVF cycle. These are all IVF patients. And what they used in terms of their protocol was a urinary product for stimulation. But importantly, what they also had was progesterone as their agent to prevent ovulation. So this is called PPOS, which is a progesterone primed ovarian stimulation. And so they all had PPOS. That's what they used for everybody. They were using what we call Provera, medroxyprogesterone acetate. And then there were some differences in how they triggered some of the patients. So some patients were triggered with 5 to 10,000 units of HCG, and other patients were triggered with a combination of gonapeptyl, which is like Lupron, and a small amount of HCG, 1,000 units, which is much more like what we do. We use a combination of Lupron and 1,500 of HCG or lower, depending on the estrogen level. So some of their patients got HCG alone. Some of their patients got the dual trigger. This is important because you want to compare apples to apples, and some of this is apples and oranges, so to speak. Everybody got triggered when they had 3 follicles or more that were 18 millimeters, or at least the maximum number of follicles that were 18 millimeters. And they only aspirated the follicles that were greater than 10 millimeters. So if it was less than 10 millimeters, they left them. That actually makes a lot of sense because there's pretty good data showing that if you don't even have a 12 millimeter follicle, the chances of yielding a mature egg from that follicle is virtually negligible. So this all made a lot of sense. And then they took the groups and they turned them into 5 separate groups. So group 5 was the controls. And then they had young, unexpected poor responders, older, unexpected poor responders, young, expected poor responders, and old or older expected poor responders. And they kind of went through the different groups. So fairly high numbers, as you can see there. If you go to that graph, the numbers are in the thousands for each group. So the control group had 8,753 patients in it. Group 1, 4,470. It was right back there where you were. You can go back to that table. It's at the top of it. Group 2 had 2,270 patients. Group 1, 1,110 patients. And Group 4, 1,095. If you scroll down that article there, the first table will come up dark. Just go down a little bit. Yeah, right there. Perfect. So there were differences between the groups in terms of age, and that was already predetermined because they had 2 separate groups, younger and older. So in the younger group, you're looking at a mean age of around 30, and in the older group, 38. And in the unexpected poor responders, it was 38. In the expected older poor responders, it was 39. No other really huge differences between the groups. Everything else was essentially very similar. Nothing that was dramatic, but important factors for everyone to look at there and to just be aware of in terms of the outcomes. When you go down to the next table, so if you can go down to the next table there, Tarek, at the very bottom, you will see the cumulative live birth rates. And that is in the bottom 4 rows there. Yep, you just passed it, actually. I think. Is that table 2 that you're looking at there? Yeah, we want to look at the bottom of table 2. So, yeah, right there. So the cumulative live birth rates are demonstrated there. And they had 2 different calculations, guys. So there's one that they called their optimistic, which was assuming that people that stopped their treatment actually had the stable same rate of outcome after they stopped treatment. The other outcome was that people that stopped treatment had 0 chance of getting pregnant, which kind of makes a little more sense. Neither of those 2 systems are precise. There's probably somewhere in the middle, and the authors admit that. But nevertheless, I think the conservative estimate is probably the better one. So if you look in the conservative estimate for the 2-year data, 64% of the patients that were young and unexpected poor responders got pregnant. 42% of the older unexpected poor responders got pregnant. 55% of the younger expected poor responders got pregnant. 26% of the older expected poor responders. All of this being compared to 70% in the group that were good responders. So important numbers for you to be aware of. When they extended it out to 5 years, you can see that 66% in group 1, 44% in group 2, 58% in group 3, 27% in group 4, and 72% overall in the conservative estimate. So not a big increase in those numbers, and that's really important to be aware of. And we're going to show you that in graph data in a moment. So this is critical because some people will try over and over and over again. But what this is telling you is that actually after that first 2 years, you're probably not going to see a huge increase in success because it's incremental. And so they graph that out. So if you scroll down further, the first 2 sets of graphs you're going to come across, next page down there. Yeah, right there. So the one on the left is again the optimistic numbers, and the one on the right is the conservative numbers. So this was the graph based on the time spent trying. So they have those 2 blue lines going up and down, and you may want to expand that just to focus in on the that right-sided graph, Tark, if you can. Yeah, the other one. That's it. And just scroll down a little bit. So the orange line is the older expected. The bright green line is the older unexpected. The kind of burgundy colored line is younger expected. The forest green line is younger unexpected, and then the black line at the top is the control group. So what this shows you is that once you hit 2 years, there is very, very little movement in terms of percentage increase in success. So basically, once you've gotten to that 2-year mark, you're really not going to see a significant increase. You're looking at maybe 1% if you're in that older unexpected group increase after the first 2 years. It does not make a significant difference. You're not going to see a huge increase. And so that's very important for people to know, because a lot of people invest a lot of time and a lot of money into this and are not seeing the outcome. And this is telling you it's very likely that you will not see the outcome you desire, because after 2 years, it's very, very minimal change. 1, maybe 2%. It's very significant up to 2 years. So you're going from 0 up to 26%. But between 2 years and 5 years, you're really only seeing a 1% in that older expected poor responder group. So if you know you're a poor responder, you've spent 2 years trying, you can anticipate that trying more than 2 years is really only going to yield you about a 1% increase in chance. It's very similar with the other groups. So the older unexpected poor responders, again, a very, very minimal change, 1 or 2%. You get a little bit more when you move into the younger group. So the younger group has a little bit more wiggle room. But after 42 months, so 3.5 years, there was virtually no change in any of the groups, including the normal responders. They still didn't have a significant rise either. So after 42 months, no matter who you are, it's time to consider an alternative approach, because you're not going to get the outcome that you're necessarily looking for. Excuse me. So if you go down to the last set of graphs there, and you can focus on that right side again. Yeah, just maybe flip that to the big screen so everybody can see it. So this one was the same depiction, but yeah, we want to go to the graph. It's the little hatch marked kind of graph. Go down, I think. Yeah. Yeah. So this is the same thing there, and maybe just reverse it. So I'm the little picture and that's the big picture. There you go. So this is in terms of number of FET cycles. So if you didn't want to look at it in terms of time, but you wanted to look at it in terms of the actual number of cycles that you've done, It's kind of similar. After 3 FET cycles, you're seeing a very minimal increase in some of the groups. And then after 6 FET cycles, you see no increase. Now, the important thing here is people already had started asking me, were these PGT tested embryos? Are they day 3 or are they day 5? So here's some interesting data. Approximately 85% of these embryos were actually done on day 3 transfers. So this is impressive because they're getting pretty decent success rates overall with day 3 embryos. And number 2, because a lot of them are day 3 embryos, none of these are PGT tested. There is data from Richard Scott's group, which demonstrates that you can get up to 95% success rate with 3 PGT normal embryos, and that for the 4.8% that don't get pregnant with the 3 embryos, if you develop one more genetically normal embryo, you get another 60% of that 4.8%, which is roughly 2.5-3%, pregnant as well. So you can get as high as about a 98% overall success rate with 4 genetically normal embryos. The problem is they don't tell you how many cycles of IVF it takes to get 4 genetically normal embryos, and it can be an enormous number of cycles. So in a state where it's mandated and they have to provide you with insurance coverage, it's not unreasonable to continue trying until you get your embryos. But based on this data, it's actually telling you that after a specific period of time, you are unlikely to have the opportunity to see a significant increase if it's been more than 3.5 years or more than 6 embryo transfers. Now, this probably falls in line with assuming that many of these embryos would end up being normal, especially in the younger group. In the older group, you're assuming it's going to take 6 embryo transfers just to see you develop, 1 or 2 or 3 normal embryos. So I think that data is very, very impressive. This is very significant for helping guide us in terms of telling you what your success rates can be and how long you should try for and how long it's reasonable to continue trying, because at some point we as physicians need to draw the line for our patients sometimes, because IVF can be kind of addictive and people pour their heart and their soul into this, and many people just don't want to give up. But at some point you got to be realistic and say, well, I think you've put in enough effort at this point, and it's time to consider alternative options, whether that's a donor or a surrogate, or a break or a change or surgery or something is different for every patient. But if you've tried 6 cycles or 42 months, you're not going to see much of a benefit by going further. So I hope you guys found that useful. I know for some people, it gives them kind of a concrete, tangible goalpost, and that's helpful. And for others, it can be quite disappointing because they want to continue trying. And there's nothing wrong with trying, but you got to be reasonable about what your expectations are. And it's important that we as physicians give you reasonable expectations. Excuse me. So I hope you liked Fact or Fiction. If you liked it, make sure you comment, hit the subscribe button on YouTube, and follow us on Instagram and Facebook and Twitter. And we're going to start taking your questions live now. So I will try and maintain my voice for as long as possible. But as you can see, I'm coughing up a storm here. So I will do my best to keep going.
First question. Hello, Dr. Victory. Asking for someone else. Do you recommend intralipids and HCG wash before the first transfer? No history of repeat miscarriage.
No, we don't normally recommend it before first transfer unless you have a very low number of embryos available. So if you're dealing with only 1 or 2 embryos, then it's certainly something to consider. But if you have a normal number of embryos, there's really no benefit to doing HCG wash and intralipids as part of a standard kind of approach to IVF. So we do use it for patients when we anticipate there's going to be a problem. But aside from that, if it's their first time and you have multiple embryos, no, I don't think you need it for most cases.
Hi, Dr. V&T. Welcome back. We missed you. Hope you had a good trip. When do you taper off prednisone? 9 weeks or 12?
Yeah, so I take it on a case by case basis. I can't say that I generally taper people off before 12 weeks. So normally at a minimum 12, depending on why we put people on it, we might even continue them throughout the pregnancy. So it varies from case to case, but in most cases, we'll start tapering people off after 12 weeks. And I go down by about 5 milligrams per day every like 3 or 4 days.
Does COVID have any effect on future implantation? Canceled cycle because of COVID positive.
So if you look at the data, they suggest that the COVID infections and the vaccine do not have a significant impact on your fertility outcomes. However, the pregnancy data definitely showed that if you got COVID and you were not vaccinated, there were higher risks of complications in the pregnancy. And we know that the vaccine creates an enormous amount of immune response initially. So I maintained my recommendation throughout the time that you should wait 2 months because biologically, even though they were saying it didn't make a difference, it didn't make sense what they were saying. And I'm a believer in science, but I also believe that common sense has a role to play. So, when it's clear that the vaccine or the virus caused this immense immune response, then it doesn't really make sense to do embryo transfers at that time or to try to conceive at that time, because inherently we know that kind of level of immune activation is detrimental to pregnancy in terms of conception and in terms of increasing miscarriage rates. So we typically tell people wait 2 months.
Thoughts on giving up sugar for FET?
Well, yeah, I wouldn't give up sugar for anything, but I'm looking at some chocolate I have stashed to the side here. So I don't think that you need to give up sugar. I think extremes are not beneficial to people. So there is no evidence that completely giving up sugar is beneficial. If giving up sugar was beneficial, there would be entire cultures wiped out because they are based on sugar. So I don't think that that's particularly useful. I think being judicious and being cautious and careful is very reasonable, but I don't think you need to give up sugar entirely. The stress from giving up sugar is probably far worse than the benefit that giving up sugar would offer you. So I wouldn't try giving it up completely. You might want to tone it down if you're a high sugar intake and need to have 4 brownies and 3 cookies and a scoop of ice cream every day. That's not a great plan. But if you're having a little bit of fruit or there's some starches in your diet during the day, I mean that's normal and it's part of a balanced diet. So as long as you maintain a balanced diet, you're going to be fine.
The cost of using donor eggs is very high here in Canada through agency plus IVF costs. I'm looking at doing donor egg embryo abroad in Europe as it costs less. Any
Yeah.
thoughts or experience with those?
Yeah.
And when choosing an egg donor, what should I look for to optimize results?
So let me answer the first part and then I'll answer the second part. So it is expensive. There's no question. It's pricey to do this in Canada because of agency fees and then the IVF fees and so on. So looking abroad is a very attractive choice. However, I've lost track of the number of people that have gone abroad, spent thousands and thousands of dollars, ended up with nothing, and then came back with nothing. So it is not a worthy investment. Obviously, war torn Europe right now because of what's going on in the Ukraine. Ukraine had a huge fertility tourism industry. I just met with some Ukrainians in Milan at the conference we were at, where they said that they've literally moved their embryos multiple times in order to avoid the embryos getting damaged under bombing and so on. So I have other patients that have done it in Cyprus and had nothing but bad experiences. Many of them couldn't get their embryos out when they wanted to move to a different center. One of the gentlemen I work with paid $5,000 or $6,000 US to a surrogate. She never showed up. You don't know who the egg donors are, you don't know how old they are, and you're only getting a few eggs. And if it doesn't work, they just say, oh, sorry, try again. So it is not like getting care in Canada. And I never recommend that people go outside of Canada for this kind of treatment. It is not worth it at all. In terms of the characteristics that you're looking for, the characteristics you are looking for in a donor. So we actually have them on our website, but it's a reasonable age. So we would say like 21 to 32 maximum, preferably 21 to 28. Normal body mass index, no smoking, no drinking, no drug use, good genetics. So you want to make sure that they don't have any genetic diseases and that your sperm source doesn't have anything where together with the egg donor it would be a problem like cystic fibrosis and so on. You want to make sure that she is psychologically stable. And you want to make sure that if she's done it before, you know what the outcomes were. You cannot get that kind of information from the places that do fertility tourism. They won't even tell you the age of the donors. So you have no idea what you're getting. And I know that for a fact because we've tried to get information on donors for the embryos we're trying to import, and they won't give us any info. So it is very, very difficult to know what you're getting when you do it overseas.
Um, my mother's sister has both MTHFR mutation genes.
Okay.
Hi, doctor. What are the chances that I have it too?
12.5%,
That's
possibly. It depends on whether your mom has it or not. So it's impossible for me to answer that officially, but at least 12.5%, possibly higher. It would depend on whether or not your mom's a carrier, right? So if your mom's a carrier, then you've got a 50-50 chance you are. If your mom's not a carrier, then it's zero, unless your dad had it. So it depends on the chances. But the fact that your grand aunt, or sorry, your aunt had it, means that you've got a 12.5% chance.
how much letrozole do you recommend alongside a depot-lupron? It's 2.5 milligrams enough. Do you recommend adding a progesterone pill as part of this protocol?
If you're talking about the 3 months of suppression before doing an embryo transfer, you do not need progesterone. And we use 5 milligrams. So it's Lupron 11.25 plus 5 milligrams of letrozole daily.
Hi, Dr. VNT. Diagnosis with a SCH at 8 weeks. Had 3 bleeds, so doctor stopped Lovenox and aspirin. Is there anything else that can be done?
No, I mean, make sure you're continuing on your progesterone. Take it easy. Reassure yourself that things are okay. Don't strain. Don't lift anything heavy. We'd probably tell you to have pelvic rest, meaning no nookie or fun stuff for a while, just to minimize the chances of complications.
What's your advice for getting through the 2 weeks wait of a third embryo transfer after multiple failures? My anxiety is very high.
Well, your program should have something available for you. There was a recent study that said that if the doctor just even reaches out, it has a huge benefit during the 2 week wait. So we're trying to figure out a way for us to do that. It's a lot of phone calls, obviously, but I'm going to start doing that. So talking to your doctor can help, or at least a team member, whether it's the nurses or your lab or whoever you want to chat with. Um, I think the best advice I've seen so far is just do the stuff you like the most. So ask yourself, what is my best day? And whatever that best day is, just create that best day every day for the next 14 days. And you'll never regret that, right? So if your best day is you start your day with a walk, and then you have a nice breakfast, and then you read something funny and you're off to work, then that's great. Do that. If your best day is wake up and have sex, then do that. If your best day is, you like to go for a light jog, then do that. I mean, whatever works for you, that's what you want to do. Just tell yourself kind of, this is my best day, and this is what I'm going to do for today.
My thyroid levels have been high the last two blood tests. How can I lower them quickly so I can do IVF?
Well, it depends on what you mean by thyroid levels being high. If you're referring to your TSH being elevated, you need some type of thyroid supplementation. So, levothyroxine, altroxin, synthroid, you need to take one of those to reduce your TSH level. If your TSH is low, meaning your active T4 is high, you need methimazole or propylthiouracil. So that's a whole other level of involvement. If you have antibodies, you need supplements like selenium and inositol that can help. And very importantly, if this is related to a Hashimoto's or a Graves', you need it stabilized before you do an embryo transfer. Rushing will not help you, or IVF for that matter.
Failed the first FET with DEs. Would you try another FET before changing things? What is a reasonable to add? ERA and PRP was recommended. Negative endo BX. No problems getting and staying pregnant prior. I'm 49 with HTN.
Well, I would definitely control your hypertension. That's super important. If weight is an issue, I would deal with that as well. Depending on how young your donor was and how good your embryos were and where you got them from, then I would be hitting the pause button and figuring out why it didn't work. We have very few failures with donor eggs. So I would want to explore the possibilities of why. The ERA test is officially essentially dead. The guy that we've been touting this for years. The guy that actually developed it has been thrown out of the company because they realized that what he did at the beginning was apparently fraudulent. I'm hearing this secondhand, so please don't quote me, but he has been tossed out of the company because what he said he had done to validate his results, they found out he had never done. And it's actually being spun off of iGenomics. It's part of a separate company now. So the ERA test is useless. Do not do the ERA test. PRP is actually valid for patients that have failed unexplained transfers because there is data that we presented on the show previously demonstrating that for unexplained failures, PRP can significantly improve your results. So that's something that is worth considering. But I would still want more information about you and making sure it's not any of the other things that are going on. With regards to endobiopsies and things like that, we believe in checking for the microbiome. We don't do it by biopsy though. We just use Fertilysys, which can do it straight from your menstrual blood. So those are reasonable things to consider. I don't think that you need to have endometriosis checked because it doesn't sound like you had problems before, but I would need to know more details about you to be able to figure out if that's reasonable or not.
Welcome back, Dr. V. Hello, T. I'm trying to do it as though we're together, you know.
Yeah.
Why does an FET protocol require starting off with a cycle of birth control pill?
It doesn't necessarily. It depends on your cycle. So some people use it to control when they're going to have their embryo transfer done. And other people need it because they're not ovulatory. But you don't always have to be on birth control for it.
I'm starting PIO injections for the first time. Any advice for me or my husband who will be administrating them?
To your husband, wear Kevlar because women can be very unapologetically violent when receiving a progesterone and oil injection. Yeah, it's painful for sure. It's not a comfortable shot to receive. So be sympathetic as the husband and understand that she's going through hell for you and your family. And then for the women, a lot of talk about keeping the area warm. First, some people actually warm the oil as well. That may help a little bit. Pinch the area pretty hard. That seems to help a little bit. Make sure you're actually in the muscle and not in the fat, because when you inject it in the fat, it hurts even more, and it tends to give you those giant pink welts. So you don't want that.
And there it is. Recommendations on how to deal with Lupron side effects. Does the add back pill as a way to combat symptoms counter the suppression efforts?
Um, so there is no way to combat it without taking hormone therapy, which is essentially called add back. The data for endometriosis and for fibroids demonstrated that taking AdBac does not negatively impact success. However, we don't know if the same thing is true for an embryo transfer. So remember that the data for fibroids was looking at fibroid size, and the data for endometriosis was looking at pain. But neither of those two were fertility related outcomes. So we don't know about fertility. I certainly don't encourage my patients who are trying to suppress to take AdVac, because in theory it's undoing the suppression. So if you can avoid something, avoid it. Having said that, the severity of the symptoms that you receive or get as a result of taking Lupron is not insignificant, and it would be ignorant of any of us to tell you to just kind of suffer through it. So I think you need to think about that.
Um, my normal TSH level is 1.5, but while taking any kind of IVF meds, they raise my estrogen. My TSH goes to 3.5 with a small amount of antibodies. Is this normal? Will a fresh transfer fail because of this?
No, it is normal. A lot of women's thyroid hormone level will fluctuate based on their estrogen levels. No, a 3.5 is not going to cause you to fail. It can have some neurodevelopmental outcomes on the fetus, but I would just watch it carefully and maybe micro adjust your dose as you're going through your cycle. So you may need a little bit more when your estrogen's going up and then less later on. Your estrogen can be avoided by taking letrozole, and quite frankly, should be by taking letrozole instead of taking estrogen. There was another study just being published which demonstrated that letrozole uh, cycles are more successful than taking natural cycles. So we knew from other studies it was better than taking hormone replacement cycles, and now it's better than normal cycles. So we've been doing this for about a year and a half to 2 years now. It's pretty much ironclad that letrozole is better. So we strongly recommend that for our patients. And it should have less of an impact on your thyroid because your estrogen levels don't go as high.
Hi, Dr. VNT. I am 36 years old. I have noticed my periods become shorter and lighter every 24 days or so instead of every 28. Can this mean my uterine lining is thin and affect on for future fertility?
Yeah, I mean, changes in your cycle with age are common. If you're noticing it enough to think that it's significant, you want to do tests of your ovarian reserve just to make sure that your ovaries are not getting weaker than you would anticipate that they should. So, get your AMH checked, get your vitamin D checked, get your other hormones checked, thyroid, prolactin. Um, do an antral follicle count, make sure everything's normal.
Second FET with donor egg, donor sperm, drug protocol, estrogen pill, oral vaginally to increase levels, and PIO shots. Normal RPL panel, negative immune test results, added inositol supplements. Thoughts?
That all sounds good, but I guess I'd be asking if you had donor embryo essentially, because the sperm and the eggs were donated. I would want to know why you failed the first time. So, is there something immunologically wrong? Do you have a thrombophilia? What's your body mass index? Do you smoke? Are there any bad habits? Is there an infection in your uterus? So those sorts of things would be important for us to figure out.
Doctor, you give such positive energy. I'm so glad to have found you. Thank you for all you do.
Well, thank you. I appreciate that. I'm not sure how positive I am with this frog voice, but I'm doing my best here. So,
We have a
yeah.
couple of similar questions back to back from Instagram. I'll share it with you. So, number one, and this question's the best question of the day. Um, do you do the ERA test?
No. So, I don't do the ERA test unless you have a very thin lining and we can't tell if there's a chance that it will allow you to get pregnant or not. So the ERA test has been proven to be useless. No one should be doing the ERA test. They just demonstrated that the whole foundation for the ERA test was fraudulent. So it doesn't work. It's been tried multiple times. It's been proven not to work. It's a useless test. Um, don't do that. Yeah, it's a total waste of time and money. Um, it's been spun off from the company. The guy that started it is out of that company. He was tossed out of the company. There is no reason to do an ERA test anymore.
Similar question, but slightly different. Do you believe in doing the ERA test before a transfer?
No, I don't believe in the ERA test, period.
There it is. I'm also concerned I didn't do PGS on donor eggs before BC because of Roe versus Wade overturned. What are the risks for doing PGS testing after frozen?
Yeah, so that's a great question. You know, it's so variable in the literature. So in the literature, there are some suggestions that it is a disaster, and then there are some suggestions that it's completely okay. I just spoke with an embryologist that is running a genetics program that's quite substantial. And this was in Milan, a lovely lady. And she said that they've had embryos that they've biopsied 4 times. So thaw, biopsy, well, biopsy, freeze, thaw, biopsy, freeze, thaw, biopsy, freeze, thaw, biopsy, freeze, and then thaw, and then transfer. So, innumerable. And she said they still had successes. I don't think that I would support that because I think that's crazy. But I think ultimately, if you are, trying and you don't have any other choices, then it's reasonable to do it. Would I do it for donor eggs? Never. The only reason we at VRC will do donor egg embryo testing is if you're using a surrogate, and it's only because of the fact that there are surrogates that will not terminate a child with Downs, and this can create quite a bit of a kerfuffle for families that don't want to have a child that they're not taking care of, and at the same time don't want to have a child with Downs. So that's a valid reason. In the new post Roe versus Wade world, um, I'm not at all going to get into the politics of that. However, I will say that I can understand the impetus to do genetic testing on embryos more widely now because people are not going to want to have to struggle if they find out that their embryos are genetically abnormal. So I certainly respect the fact and recognize the fact that there will be an enormous increase in the use of PGT in the US. Your alternative is to spend about a quarter of that money and just come to us in Canada and get it done here where you don't have to worry. So I would happily help anybody out that needs that kind of assistance.
Thank you. You guys are the best. You're so
Oh,
honest, and I appreciate you so much.
well, you're welcome and thank you for watching. And I'm sorry I keep hydrating, but my voice is going. So, yeah.
If someone has HSV2, is it recommended to take Valtrex before an FET? I often react to the fertility meds with a flare up, so I wonder if that could be impacting the transfer.
Well, if you're having a flare during your transfer, I wouldn't even try, because that's not a good time to do an embryo transfer. So yes, you can try suppressing with a Valtrex or something like that. There's some weak evidence that HHV6 actually has a very negative impact on implantation. I've tested a bunch of people for it. I still have yet to find a single person that tested positive, but it has been reported to be a cause of failed implantations, recurrent failed implantations. So I can't say that there's a harm to taking Valtrex or suppression before an embryo transfer. Certainly, if you're having flares, I wouldn't even allow you to do a transfer. It just doesn't make sense. Yeah.
How many months of suppression do you recommend? My protocol is 2 months of depot Lupron and letrozole, then moving straight into a transfer with low dose estrus and letrozole.
So the study showed 3 months of Lupron and letrozole, and then you should be moving into a letrozole protocol for your embryo transfer, and only using estrogen if you absolutely need it. We don't use any unless we have to.
Do you prime all your patients before doing stims during an IVF, assuming their fertility diagnosis is unexplained?
No, not at all. I mean, if you're unexplained, priming isn't going to help you. So you don't need priming. Yeah. We prime depending on what you're doing for priming. We prime people with human growth hormone if they've previously not had enough eggs or not enough mature eggs. We prime with testosterone because there's pretty good data now that it supports an increase in live birth rate. That was something that was there in our meeting in Milan. I don't estrogen prime. They just did a randomized controlled trial demonstrating it doesn't help you, so that's of no use. So I'm glad I never got into that because it doesn't work. So yeah, we use DHEA. We'll use birth control for some people, and growth hormone priming, and we use testosterone priming. So all of those have shown some benefit. Estrase has not, but we don't prime otherwise, and I don't use it for everybody. Only the ones that need it. Yeah.
Dr. V, you sound great. Sorry. Sorry, Milan treated you badly by leaving you with a cold. Speaking of fertility, which I finally did, still unclear why the US doesn't do these types of microbiome tests. IT.
IT. Well, thank you for my my voice. I find it quite funny. It's like the super deep voice me. So Fertilsys does what they do and are successful at doing it because they've created a really interesting product in a very niche market that's under high demand. Why is it not done in the US? I'm sure it is. It's just probably triple the price, like everything else in the US. These guys are doing it in Greece. The Greece, as you all know, is heavily economically burdened. And so you can get cheap supplies and cheap labor and cheap everything there. So it's much easier to do this kind of thing there than it would be in the US, where wages and costs. You okay?
Yeah, I'm good. Can you hear me?
Yeah, I can still hear you.
Okay. What BMI index max do you suggest to optimize results?
If you're over 35, it's a very significant decrease in your success rates. So we almost always want to see your BMI under 35, preferably under 30. So that's what we target. If you're over 35, generally speaking, I will tell you to hit the pause button and get it under 35. There are exceptions. So there was a really well done Chinese study Tark and I reviewed years ago on the show, which demonstrated that at 38, there was this kind of crossover between where your fertility was more compromised by waiting longer than your weight compromised it by being over the ideal. So if you're over the age of 38, you should just go ahead with fertility because your age is more important than your weight is. But if you're under 38, you should lose the weight first.
Will PGS testing my embryo help us figure out why I have issues with implantation? A few chemicals, early miscarriages with IUI, natural, and moving to IVF.
Well, it might. I mean, there are patients who have multiple genetically abnormal embryos. And if they do, then that's something that's important to know. For the couples that do not have multiple abnormal embryos, then the PGT testing is not going to help you. Now, having said that, if you have a PGT tested normal embryo and you transfer it and you miscarry, then we know that it is unlikely to have been the embryo, not impossible, but unlikely to have been the embryo. And therefore, we need to dive deeper into figuring out what about you it could be. Do you have to do that first? No, there are tests we can do on you, like the fertility testing, that will help us determine if there's a problem with you or with someone else or some other parts. Right?
My body mass is 38.9. Is that too high for FET with donor eggs?
So that's an easy answer. And the answer is there's no such thing as too high. There is just ideal and not ideal. And because you're using donor eggs, you have all the time in the world to lose weight before doing the embryo transfer. So the question is it ideal for you to get the weight lower before doing your embryo transfer? And the answer is unequivocally yes. You will get a higher chance of success by bringing your weight down. And time is not critical for you because donor egg embryos will last forever and still give you a very good chance. So, in my opinion, in that situation, you should spend the time to bring the weight down significantly and then go for your embryo transfer. Yeah, that's a great question.
Can mycoplasma overgrowth be enough for recurrent miscarriages?
Well, that depends on who you believe, but I would say yes. So the literature on it is not so clear. In animal studies, it definitely demonstrates that. In human studies, it's questionable. But having seen it 1,000 times with all these fertility tests that we keep getting, I do think it makes a difference. Yeah.
Hello, Dr. V. I've done 3 IVF cycles without success. My BMI was 33 and I worked hard to get it to 25. Did another cycle, and for the first time ever, I got 2 day 5 nicely graded embryos. Uh, and BMI can BMI influence an outcome?
Yeah. So on our website, if you go to the resources tab and you click on weight and fertility, or is it obesity and fertility? I can't remember. Um, we have this long brochure, and if you download that, that was like a good solid several months of my life, just putting that together for everybody. So there is a load of information on how both male and female, I don't like to pick on women, BMI can negatively impact your fertility. So there's a lot of information out there for you to explore. And yes, there is no question that BMI has an impact on virtually every part of your fertility. So, from the standpoint of getting eggs to going through your cycle to getting good embryos, all the way there it is. Tarek pulled it up. Well done, buddy. Um, pull up the, is that the long brochure? Or is that the short? I think that's the short one. I can't remember. Yeah, there is an enormous amount of impact, huge, on all the different elements of fertility. So there's a lot of information there for you guys to go through. That's the short one, T. Oh my God, now I'm calling you T. Yeah, that's the long one there. Yeah, so there's page after page there, guys, that we prepped for you that reviews how it affects women, how it affects men, how it affects cycles, your egg quality, your sperm quality, right up to how it affects birth. So take a look at that. There's a lot of information to go through. And the answer is yes, absolutely. It does have a very, very significant impact on your outcomes for sure. Yeah, that's a good brochure. Park did a beautiful job.
Looks amazing. Yeah. Whoever did it is a genius. um, okay. Fevers at implantation, 101 to 105 degrees. FET 4 hours later resulted in a 105 fever. Could this be indicative of endo? Nurse said right ovary looked gray, may have endo. Appendectomy sepsis at 36. AMH 1.7 nanograms per mil, April, 0.88 May, 0.33 June, 0.40 in July after priming with HCG 80 days and progesterone estrogen 21 days. Referring to question above, perhaps endo is accelerating because of this.
That was super confusing, but your endo will definitely accelerate if you're taking estrogen. So that's a significant concern. If you're exposing yourself to estrogen over and over again, that's a problem. But as far as the AMH dropping that quickly, that's unusual. So I would want to be making sure that there wasn't something else going on. Yeah, that's a tough question to answer. Sorry.
It was tough to read, so don't worry. You did great. Have you seen COVID infections having an impact on fertility for women?
I haven't, but that's because we don't do transfers around the time of our COVID infections or vaccinations. So I've been pretty staunch about telling people to hold off. I recently had a surrogate who refused to listen to anything we said, actually. And so I actually fired that surrogate. She obviously will remain nameless. And she insisted that her COVID was irrelevant and it didn't matter. And we shipped the embryos out to somewhere else because the IP still wanted to use her and it didn't work. So I don't believe in transferring into people right after they've had COVID or vaccination. It just doesn't make sense. Biologically, your immune system is extremely, extremely activated following a COVID infection. So, one thing we know, whether you believe in all the reproductive immunology or not, we know that the immune system plays a critical role. And we know that an overactive immune system is never a good thing. I can give you 1,000 different examples. It doesn't really matter. Any autoimmune condition in the human body will decrease your chances of success with pregnancy. So, with all of that in mind, does that make sense to go ahead and try and conceive or do ART? No, of course not. So we have avoided it, and because of that, we're not seeing a change. But are other people? Well, the research says it doesn't make a difference, but I don't know a lot of places that are firing off to do embryo transfers in patients that just newly had COVID or had vaccinations. Yeah, most of us are pausing.
Uh, how can you be sure someone has endometriosis without having surgery? Question asked can be answered by the same by many women with symptoms.
Yeah, you can't answer the question of endo without surgery. There's actually an interesting article in Human Reproduction, I think, where they were claiming that you no longer need to do surgery to diagnose endo. With all due respect to all the people involved in that publication, that's a bunch of nonsense. There is no way to diagnose endo without doing surgery. BCL6, which was supposed to be the big halo thing, Receptiva DX, that's basically what BCL6 tests. They said, oh, this is so good. They just did a trial. It showed no benefit to doing that test. It is not predictive of endo. There is no test that is predictive of endo. The only way to actually predict endo is to diagnose it. And the only way to diagnose it is surgery. I did hear something super interesting from an Egyptian guy. Tarek's going to be super proud. In Milan, that they are using cell-free DNA to detect endometriosis in patients. So, cell-free DNA is like what we do for NIPT, the new testing for Down syndrome in pregnancy, where you can pull out actual embryonic cells, like cells, and DNA from the maternal circulation and then test it. So this is super interesting because they're saying they could do this for endo. I did take a moment to look it up, and the two studies I found said that it was useless. So I don't know what this guy is doing, but he claims to have patented a cell-free DNA technique for diagnosing endometriosis. So I guess we'll see. It wasn't being promoted at the meeting, so I don't know if this patent was just really new or it's bogus, but we'll find out, I guess, in time. I think I promised people an extra half hour tonight, but I don't know if you knew that or not.
I remember that. I'm obviously available. Here I am.
Yeah. Are there more questions?
Um,
Because we're at 9.
there are more. If you want to go through them, you can do it. I believe
Yeah,
you can do it.
do what we can before we.
I'm sensitive to your throat, but by all means, be the hero that you are. Doctor, will you ever have a clinic in Toronto?
When am I going to have a clinic in Toronto? I have affiliated clinics I work with or at in Toronto already. So I can only be in so many places at once. So it's difficult for me to be somewhere else at the same time. But I have gone to Toronto. I did an embryo transfer in Toronto before I left for Milan. So no, I'm back and forth a fair bit. And these days, we don't really need to be in any specific place. I have loads of patients coming to us from Europe and from the Middle East and from the Eastern countries, Eastern Bloc countries. The only place I don't think we've had patients from yet is South America. So yeah, we have loads of patients coming from all over the world. You don't need to be anywhere is specific to get to fertility treatment. It's all done virtually now, and then you just show up for your retrieval and transfer or IUI or whatever the case is.
Is a cup of coffee a day okay after an FET?
Yeah, totally. 1 cup a day is fine. Don't have more than 1 cup. They say 1 caffeinated beverage per day. The risk is actually miscarriage. So it's not failed FET, it's just miscarriage. So 1 cup a day is okay. Now, that doesn't mean go get the, big giant bottle from or cup from Tim Hortons, but one reasonable sized caffeinated beverage is okay.
Hi, Dr. Vic and T.
Vic and T, all right.
Yeah. I'm 40. I have 2 normal PGTA embryos, low segmental mosaics. I declined ERA for FET. Thoughts?
So she has 2 normals or 2 mosaics?
She has 2 normal PGTA embryos, low segmental mosaic.
Okay. I'm not sure if she's saying they're normal and then she has a mosaic, or if she's saying that she has 2 that are mosaic. So low level mosaics, there is a huge movement to stop calling them mosaic and to just call them normal, because they're saying that the outcome is virtually identical to the outcome of a genetically normal embryo. So there was a really interesting talk by the guy that probably has the highest experience with this in the world. And he works out of a program in the States. And he presented at ESHRE, where I just was, in Milan. And he basically said a low level mosaic was going to give you the same results as a normal embryo. About half of them will implant and turn into perfectly normal babies. Half will not. So you've got a 50-50 chance with those mosaics. I think his overall success rate, I'd have to pull up for you, but I think it ended up being about 26-27%, something like that, from a mosaic transfer. So it does provide you with a reasonable chance of success. The ERA test is useless. I don't know how many times I got to say that, but don't bother doing the ERA test. It's a waste of time. if anybody's watching, please stop doing the ERA test. The ERA test is done. It's over. It's a part of history. It's not valuable. So give it up. Yeah, I was a big believer. I freely admit that. And it made a lot of sense to me, but it didn't work. And that's just the reality of it.
What are your thoughts about starting Ozempic, even though we want to do an FET later this year? Told to wait 3 months after the last dose before trying to get pregnant.
Um, I mean, Ozempic for weight loss is to me a crutch. If weight loss, I had this discussion with two patients today, but and I say this with the utmost respect for everybody out there who struggles, because weight can be a real battle for many of us. But weight's easy, to be honest with you. It's math. It's purely math. So if you take in 1,000 calories a day, which is very low, don't try doing that, and you burn off 1,500, it is biologically impossible to not lose weight. It's math. Like, it can't happen. You will lose weight. And if you take in 1,500 calories a day and you burn off 1,500, you may alter your weight a little bit by having more muscle mass, but shy of building more muscle mass, you're not going to lose weight. You're going to be staying at the same weight. And if you take in 2,000 calories a day and you burn off 1,500, you're going to gain weight no matter what you do. So weight loss is math. You don't need Ozempic. You need discipline. And that's hard for a lot of us, myself included, because I see something sweet. And Tarek, my brother, there is the same way as I know that from from all the meals we shared together. We love the sweets. I see something that tastes good, I want to eat it. So you know what? It's a tough thing to do, and then exercising is not something we all have time for. So it's input and output. If you manage to take in less than you burn off, then you're going to lose weight no matter what you do, and you don't need Ozempic to help you. So the key is to eat healthy and watch your calories, and then exercise enough to get your caloric burn to be high enough that it exceeds what you're taking in.
Hi, both. Do you recommend getting Panorama or other private testings for preg patients with RPL history?
Oh, that's an interesting question. If you PGT tested your embryos, no. If you did not PGT test your embryos, it's certainly not harmful. You can get the exact same testing done from a company called Invitae in the US for $99 US. So if you're going to do it, save yourself a whack load of money and just send it off to Invitae, and they'll do it for $100 US. So that's what we do for our clients.
I wish you could reach Asia, specifically the Philippines.
Oh, wow. I don't think we've had a Filipino viewer before. Oh, you know what? We did years ago. We did. Well, listen, wherever you are, and thank you so much for watching all the way from the Philippines. You are more than welcome to access us. You just have to email info@drvictory.com. We provide consults to people all over the world, and then you just come to us for help, and we can do everything where you are and just bring you here for your retrieval and transfer. Many times you don't even need to come to me. There's a lot of people where we help, where they can, get better results right there in their home country or hometown. So I don't believe that I have to get everybody to come here. I really do this because we like helping people. And so if I can help you where you are and make your journey more successful, that's a win for me, and I'm happy with that. That's cool. Philippines. Wow. We gotta make like a little a map where we put like a little dot every time we find out we've got a viewer from there. That's cool.
Thoughts on taking Valium prior to an FET?
Yeah, a lot of programs do that to keep you calm. I don't see why you need that, but if it'll keep you calm, that'll be helpful. Excuse me.
Speaking of coffee, is it safe to drink for people with PCOS? If yes, what kind of quantities, please?
Is coffee safe to drink for people with PCOS?
Mm-hmm.
It's totally safe. Yeah. 1 cup a day. Yeah.
Ozempic question is on top of already losing weight as per protocol.
Yeah, no, don't do Ozempic. If you're already losing weight, you don't need Ozempic. Avoid medicating yourself. Years ago, there was a drug, I can't remember the name now, that people started taking because it would help you lose weight. And then they started developing pulmonary hypertension, which is a very significant, potentially fatal and permanent condition. And they had to pull the drug off the market. Weight loss is math, guys. Everybody can dance around it as much as they want. It's math. Input, output. Get your input to be less than your output, you're going to lose weight. So it's not an easy thing to do. I'm not belittling it at all. It's difficult to get your input to be less than your output, but it's math. So eat less, work out more, you're going to lose weight. It's unavoidable. It's literally math.
AMH 7 picomoles, last IVF transfer retrieved 24 eggs, 12 were mature, 6 blasts. One pregnancy then ended due to the baby having excephaly. And 41 worth trying again.
So let me get this right. AMH is 7, but they retrieved 24 eggs?
Yeah.
Well, somebody messed up their AMH because that doesn't make any sense. With an AMH of 7, it would be unheard of to retrieve 24 eggs. That sounds like something went strangely wrong. I would wonder if they overstimmed you and you had a very long stimulation phase in an attempt to get more instead of better quality eggs. I would love to poke into that a little bit more. So maybe if you want to contact me, I will make some time to chat with you. Just get a consult with us, and I'll go over that case with you because I would need to know more. My suspicion, and if you're still watching, please let me know, is that you stimulated for a very long time, maybe 14, 15 days. If that's the case, they overcooked your eggs. But let me know. I'd be super, super interested to hear about that. Yeah, that's super, super cool. And she's 40.
What should estrogen levels be for a fresh 3-day transfer? What should progesterone be also?
Well, your estrogen levels on a fresh transfer are 100% going to depend on how many eggs you had. So that's impossible to answer. Your progesterone levels on 3 days, your progesterone levels should be between 40 and 100 nanomoles per liter. So that's what we would be aiming for.
Hi again, Doc Vic and T. Normal PGTA tested and few low mosaic. 40-year-old, also in Calgary. We are put through medicated over natural FET. What's the difference?
Well, this is the ongoing battle of the fertility world these days, is what's better, a natural FET or a medicated FET. My personal opinion, based on all the scientific data that's available, is that a modified natural is best. So that's what we do. We use letrozole, which gives you kind of a modified natural approach, and we are getting incredibly high success rates. So for me, that's what makes the most sense. There is some evidence that the high hormone levels with a full hormone stimulated cycle is not ideal. And there is new evidence, very new, showing that letrozole is better than natural. So we know letrozole is better than hormone, and now we know letrozole is better than natural, which just means letrozole is best. So that's what we've been doing for our patients, and we've had great success with that.
Is it necessary to test embryos if someone has endometriosis?
Is it necessary to test embryos if someone has endometriosis? Those two conditions are completely independent of one another. So if you're 38 and you are producing embryos and you have endo, you need to deal with your endo, but then you still need to know if your embryos are normal. So those are two totally isolated issues.
And I think we got one more here.
Well, I'm about to officially lose my voice, so
Okay, we'll make it good. Well, I can't do anything about that. It is what it is at this point. It's a big one, so prepare yourself here.
all right, I'm ready.
What should the estrogen level be for a fresh 3-day transfer?
No,
And what should progesterone be also?
you asked that one.
Okay. Stim cycle, 10 milligrams letrozole, 200 IUs of fortalisim, 20 low dose HCG, 6 IU omnitrope, 1 milligram dethemexone, planquenil, E2 started at 42, but after 3 days of stims, dropped to less than 15. Is the cycle not working?
You're on a massive dose of letrozole, which is going to crash your estrogen levels. So you're looking at the wrong metric for figuring out if your cycle is working. You need to look at your follicular size. So your estrogen level is the wrong thing to look at because you're on such a high dose of letrozole, it's going to suppress your estrogen levels. So for people that are on letrozole during their cycles, don't monitor your estrogens because it'll totally throw you for a loop. You won't understand it.
And that could be everything.
Amazing. Well, thank you all for watching. My apologies for my very froggish voice here, but I hope you guys enjoyed the show. Super interesting article. I know it's not an amazingly well done study, but it's still really valuable information based on the size of the numbers. If you've had 3.5 years or more than 6 embryo transfers, it's probably time to consider an alternative option. So, but up to there is an incremental increase. So there's always a chance. Let us know if you have any questions. Make sure you hit that like button, comment, and subscribe. If you're new to us on YouTube, thanks for all the new followers. It's been growing like crazy recently. I think YouTube started promoting us, so that made a big difference. We're now over 700,000 views. Have a good night. We'll see you next week on Fertility Fact or Fiction.